good.
Okay.
Thank you.
Okay, let's go ahead and get started this morning. Today we're going to be talking a little bit about differentiation of upper motor neuron and lower motor neuron components, and then we're going to talk a little bit about spinal cord, because that's one of the ways you really differentiate, and that's where we see a lot of the problems with upper motor neuron dysfunction. First of all, anatomy is where you really decide what's lower motor neuron and what's upper motor neuron. And so what are the structures that are going to be involved that are going to give you lower motor neuron symptoms? These are the list of them. And you're going to have roots, you're going to have plexus, you have nerve, you have anterior horn cell, neuromuscular junction, and muscle. Okay? Those are the 6 components that involve the peripheral nerve system. And if you have involvement of those, they can be lower motor neuron signs. If we look at what constitutes upper motor neuron, okay, it starts in the motor cortex, which sits where? In the frontal lobe, then goes down through the corona radiata into the corticobulbar, and then the corticospinal tracts. So any involvement of those areas produce upper motor neuron symptoms. Involvement of the 6 structures I showed you earlier would be lower motor neuron. So that's why it's very, very important to understand the difference and differentiating, because it takes you into which system you're dealing with. And it has to do with pattern recognition, and it has to do with the signs and symptoms that exist in one and not the other. So if we look at anybody clinically, there's a lot of things that I'm going to be showing you some cases which will point this out. But upper motor neuron is going to involve the spinal cord, the brain stem, and the cortex, and all the connections in between. That's upper motor neuron. And then what do we have coming off of that? We have cranial nerves, which are lower motor neurons, and then you have all your spinal nerves. So, for example, how do we localize problems? Let's say that I have a problem in my C5 root on one side, and I find upper motor neuron signs as well. It's going to tell me where my location is. So we use the different signs because patients can have both. They could have just upper motor neuron, or they could have just lower, or they could have combinations of both. And then it's a matter of localizing it once you know that information. So if we look at lower motor neuron, where does it start? It starts in the anterior horn cell, goes out through the root, and then what's it do? It goes into the plexus, it goes into nerve, it goes into muscle, and we have the neuromuscular junction. So the difference between those, and I'm going to be going over that a little bit more later this year, but we make the differentiation of different lower motor neuron processes by what's involved. For example, if it's anterior horn cell, there's a specific pattern. If there's root, there's going to be patterns. For example, it would be just C5 muscles or just L5 muscles. We get out into plexus, what's going to happen? It's going to be one extremity. It's not going to fit a root pattern. It's not going to fit a nerve pattern. So it's going to be one extremity with a mixed root nerve pattern. That's plexus. Mono extremity, mixed root, mixed nerve. Root's going to be a particular root. Then you get your mononeuropathies. Only those things that involve, for example, ulnar or perineal or tibial or whatever. So again, it's your distribution that you see. We have muscle disease, which produces what? Proximal weakness. And then we have neuromuscular junction, which we're going to have a whole lecture on. But that's where we have fluctuating symptoms. And then there's specific patterns, which we'll talk more in detail later. But anything that involves those is going to be considered lower motor neuron. Now, some definitions that you need to be aware of. One is fasciculation. And what is a fasciculation? It's the spontaneous firing of a motor unit. And what is a motor unit? It's one anterior horn cell and then all of the fibers that it innervates. So when you have a muscle, what happens, that anterior horn cell goes out and it sends lots of fibers out. And those fibers are spread throughout the muscle. So for example, one anterior horn cell may have fibers throughout the triceps in different locations. They don't just go to one little location. And that's why there's so much overlap. That's why we can have damage of cells and you still have ability to do things because not all of them were knocked out. In lower motor neuron processes, when you have destruction of neurotissue, you get spontaneous firing of that motor unit. And that's what we call a fasciculation. Now, you can see fasciculations under the skin of muscle. I'm going to show you one here in a minute. But what it is if I'm real fat, I can't see it because what's going to happen? I have fat. So we never see them back here because everybody's fat back here, okay? But we do see them in the fingers. You can always see them in the tongue because those are very superficial muscles. So your chances of seeing. So somebody can have a fasciculation that you might not be able to see clinically. And the reason you can't is because of that. So that's why we can put a needle into the muscle and look for fasciculations by doing a needle examination as well as observing. But if you see a fasciculation, you know you have lower motor neuron process. Okay? So if you ever see somebody with a fasciculation, you know one of those 6 structures we just talked about is being involved. Okay? Fibrillation is the spontaneous firing of a single muscle fiber. You cannot see that. The only way you can find that is putting a needle in. If I see a fibrillation, it really is telling me similar to this, but it's telling me that something actively at that time is going on and that there's damage. So if I put it in, they've got fibrillation and fasciculations, it's a chronic active process that's lower motor neuron. Now the other thing you need to understand is tone. What is tone? Tone is defined as a resistance to passive motion. So if I take somebody's extremities and move them, there's going to be a resistance, and there's different kinds of tone. And we're going to get a little bit into the different kinds here in a minute. So, lower motor neuron syndrome. It's damage to a motor unit. It produces weakness. The distribution of the weakness is how you differentiate it. You have atrophy. And atrophy occurs because you get destruction to the nerve, and we lose the ability, and the muscle actually starts atrophying. We have reduced DTRs that occur because of the loss of that reflex arc being damaged. We have reduced tone or normal tone. It can be normal, but you can have reduced tone because you're getting lower. You're not going to have hyperreflexia. And you can get fasciculations and fibrillations. So those are the characteristics of a typical lower motor neuron syndrome. Now, here is a fasciculation. Have any of you ever seen a clinical fasciculation? But if you look at the muscle here, you see them underneath the muscle, these little movements? Kind of undulating type movements, and you can actually, what those are different motor units. That's fibrillation. It's very different than jerks or spasms or cramps. I mean, those are totally different types of phenomena. There's myotonia too, where you get stiffing, but the whole muscle gets stiff. But these are little fibers. You really need to inspect somebody to look for those. I mean, you have to take the shirt off, take the pants off, and look for them in all the different muscles if you really want to know if they exist or not in a given individual. That's a class of fasciculation. Now, so if we look at this is a very important graph, and I know you've seen this before because you had it in first year, all right, in anatomy. And this is how we differentiate the 6 components of lower motor neuron. And the first thing, DTRs, because they're lower motor neuron structures, what is it going to tend to be? All of them can be decreased or normal. We look at tone. It's going to be normal or decreased. That just does nothing more than telling you it's a lower motor neuron. We can have fibs and phasics. All of them can have that because they're all lower motor neuron processes. And then we get into the two things that help you differentiate the 6 components. And what is it? First of all, do they have sensory symptoms or they do not? And think about it. Anatomically, anterior horn cell is pure motor, muscle is pure motor, and neuromuscular junction is pure motor. So what are they never going to have? They do not have sensory symptoms. So if I have sensory symptoms with lower motor neuron, if I have numbness and tingling in my arm with atrophy and fasciculations, guess what? You've got 3 choices. Okay. And then you look at what? You look at the distribution of the weakness. Anterior horn cell, the way the disease, we say it's asymmetric, so it can start in the head, it could go to an arm, it could go to the leg, it could start in one leg, go to another leg. There's no rhyme or reason of where it goes. The other thing, it's going to have no sensory symptoms, and it's going to be atrophy, fasciculations, and so forth over time with weakness that's in that distribution. We look at muscle disease. Muscle tends to get proximal weakness. That's the pattern. It's going to be more generalized. We look at neuromuscular junction, and we'll talk more about this in detail later, but you get 2 main patterns. You get what we call ocular or bulbar, and ocular means that you get double vision and ptosis and stuff like that, and bulbar would be chewing and tongue and that. That tends to occur in older men with the disease. Younger women tend to get generalized weakness with it. Those are the patterns, but the other thing is it fluctuates. No sensory symptoms. Then we get down to root, plexus, and nerve. Root's going to be, well, if it's C5 muscles. In fact, just walked over here, saw a lady with a C5 radiculopathy when I left the office. She was weak in her deltoid, her biceps, and her external rotators. She had loss of her reflex in her biceps, and she also had weakness in her brachioradialis. Classic C5. And you would see that in plexus, as I've said, it's always going to be one extremity. It's going to be a mixture of root and nerve. You're going to look at it and say, boy, this is more than that. They tend to be more upper or lower because a lesion tends to get upper plexus or lower, but it could be widespread in the plexus. But it's always going to be one extremity. And then we have the nerves, and those are knowing the mononeuropathies, knowing ulnar nerve, knowing perineal nerve, and it's the muscles in that distribution. So, whenever you see somebody clinically, the way you differentiate it is examining them and finding out what is the distribution of the weakness, and do they have signs of lower motor neuron disease, and if they do, you're looking for one of those 6 patterns. If you know those 6 patterns, it's going to be very easy for you. And they're really not hard. You need to know 7 patterns. These are 6 of them. Now, we go to corticospinal, which is going to be upper motor neuron. And if you remember, where does it start? It starts up in the frontal cortex, goes down through the corona radiata, goes through the internal capsule, gets down to the basis, goes to the basis pons. It goes all the way down to what? The lower medulla. Okay? It then crosses the pyramids, and then it goes down in the lateral corticospinal tracts. Okay? Anything that affects anything along here is going to produce upper motor neuron signs. Now, does anybody here, can you tell me what the pattern of upper motor neuron is? Just general upper motor neuron, not a specific location. Does anybody know what that is? Did any of you take physiology in college? Okay? They probably taught you there. Yeah. Hyperreflexia. What else? Increased tone. No atrophy, except you could get disuse atrophy, which is different than neurogenic atrophy. And what's it? That's kind of like the guy who works out and the guy who doesn't. Okay, the difference between those two. But it's not neurogenic atrophy, very different. And what are the other components? What about the weakness pattern? What would the weakness pattern be? Okay. No. Okay. All right. Anybody? Yep. Is it was your hand up, or are you just stretching? Good, 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 good. Good, good. Okay, so in the upper extremity, it's going to be extensors. In the lower extremity, it's flexors. And I always like simple things to help me remember that, so that 10 years from now you go, God, I remember a lecture. What was that? Okay. Think about a stroke. Any of you have had a family member or seen a stroke, and how do they lay in bed? They lay like this. And why are they laying like this? Is because when they got their upper motor neuron weakness, their extensors are weaker than their flexors, so they tend to pull like this. And then what happens down here, it's the opposite. Their flexors are weaker than extensors. So how do they walk? This is how somebody with a stroke. And why are they doing that? Because their flexors don't work well, so they throw their leg out so they're not falling on their face and tripping over their foot. So if I want to screen somebody for upper motor neuron weakness, what am I going to do? I'm going to have him hold his hands out, and this is a distal extensor. So you hold it there as hard as you can. Don't let me push down, okay? That's a distal extensor. And then what am I going to have him do? I'm going to have him walk on his heels, because that's a distal flexors. The other thing is distal muscles are more affected than proximal. So upper motor neuron pattern is increased tone, increased reflexes, extensors greater than flexors, lower flexors greater than extensors, distal more than proximal. That's the 7th pattern. Okay? That's upper motor neuron pattern. Any questions about that? Because that's a really important concept to understand. So, we've talked about stroke earlier. Within the upper motor neuron patterns, there are patterns that tell us where it is. And we talked about 2 of those. We talked about middle cerebral and we talked about anterior cerebral. And it doesn't have to be vascular. It could be a tumor. It could be an abscess. But if it's in those locations, so what's anterior cerebral? That's if you get in the parasagittal area. And what's it do? It produces primarily leg weakness. If we get in the middle cerebral territory, what's it tend to do? It gets face and arm. So remember, face and arm, and think leg. Those are 2 of your patterns that are up in the cortex, and it's a very simple way to remember it. Then we get into the spinal cord. Again, you have increased tone, you have increased DTRs, you can get neurogenic bladder. And why do you get a neurogenic bladder? Because you get a spastic bladder. So it does the same thing to the bladder it does to the muscles. It wants to contract more, you go more often, okay? You can get incontinence from that. And then you're going to get upper motor neuron weakness, which we're going to talk a little bit more. You can have absent abdominal reflexes because these are lost as well. You can get positive Babinski, which is a sign of upper motor neuron. And if it's global, you get some sensory things. Remember Brown-Séquard? That's a hemisection. We'll talk more about that later. So, what about spasticity? We talked about increased tone. I think for your purposes, the thing to think of is there's 2 types of increased tone. The 2 are rigidity and spasticity, and they're very different. Rigidity is more like Parkinson's disease. And what is rigidity? It's resistance in all directions of motion. Spasticity tends to have more of a clasp knife. You know, you do it and it tends to give way. The other thing is that spasticity is associated with increased DTRs, okay, where rigidity is not. Rigidity is going to have, you know, normal or decreased reflexes just because it's in that individual. If I've got a diabetic who's got Parkinson's, their rigidity is going to have reduced reflexes from their diabetic neuropathy, and, you know, it has nothing to do with the other, and or they could have normal reflexes. But their rigidity is in all directions. It's what we call lead pipe. So very different than spasticity. Now, this is an important slide that goes through. Anything that affects this tract is going to give you upper motor neuron pattern. But this tells you what's involved. So we talked about, if we go up to the cortex, What could be affected? Well, it could be just face, upper motor neuron, just arm, upper motor neuron, just leg, depending where you are in the homunculus. As we get down into the corona radiata, that's where you have the face and arm that we just talked about, or just the leg. We get down into the internal capsule. What do we see? We see face, arm, and leg are involved. And that goes down to where? To the mid-pons. And why at mid-pons is where the face takes off on the other side. So we get below the mid-pons, and now what do we have? We just have arm and leg involvement. So that would be low pons, or here, or the other place it could be is ipsilateral high cervical cord. So if you have arm and leg, there's only really three possibilities, or two possibilities of upper motor neuron. It has to be opposite low pons or medulla, or it has to be high cervical cord. Okay? And then we get down into the spinal cord, you get below the cervical area, it could only be leg. So, but all of these are going to have the characteristics of having upper motor neuron. Still extensors, greater and flexors. It may be just my leg, because I'm here. So you're not going to have the involvement of the arm, okay? If I'm here, down, it's going to be just, from here to here, it's going to be just arm and leg. Up here, it can be face, arm, and leg, and up here, you get more localized patterns. Face and arm, leg alone, and so forth. All with me on that? Because again, very important. So, you're going to see all kinds. I can guarantee you, you're going to see it on exams, not only in this course, but you're going to see them in all your exams. They're going to have somebody that comes in, and they're going to give you a case. Okay, this person comes in with weakness of their right arm and leg. Okay, and then they're going to give you some other characteristics and so forth, and they're going to say, where is that? They may ask you what it is, because they're going to give you a time sequence, and you figure out that from the time sequence. And it's very simple if you know that chart, okay, of where it's at. Now, the other thing is some other terms. When you have some indirect pathways because of all those vestibuli and the nuclei. I'll be honest, I don't want you to learn this because it really doesn't matter if you really know that, okay? I just want you to understand the concept that when you get that, that's why some of these people with upper motor neuron have trouble with their coordination a little bit, okay? These are affected, and so their dexterity is affected. You've seen the spastic people walk, and they're wanting to fall. They're not ataxia. It's not cerebellar disease. They get that because of this indirect pathway being affected, and you get that spastic. But upper motor neuron is just what we talked about. Increased DTRs, increased tone. And why do they get this is because of that, okay? Then there's a term, apraxia. That's if you get cortex, frontal cortex, and this is where you have inability to perform learned acts without having. This is a person who really, well, let's look at speech as a simple way. We have, we talk about difficulty getting their speech out with an aphasia, what we call an expressive aphasia. An expressive aphasia is really a motor apraxia of speech. What they know what to say, it's just that they can't get that down to do what they want to. They have the ability to do it, it just doesn't get down there and happen. Same thing can happen with motor. Normal pressure hydrocephalus, for example. You watch them walk, and what do? They walk like this. It's an apraxia because the hydrocephalus is producing that difficulty with initiating function. So it's a different kind. And that's why you have a tumor that's in your frontal lobes, they get an apraxia type of phenomenon. Okay, so this graph differentiates what we just have been talking about. What's the difference in upper motor neuron? Here you've got fibs and phasics, okay? DTRs tend to be increased or decreased. Atrophy, yes. Here you could have disuse. Down here your tone tends to be decreased, it tends to be increased. Clonus is nothing more than a sign of increased tone. Babinski, okay, can be seen with this, not with this. And the weakness, both of them have weakness, but what's the difference? This is one pattern, depending where you are, tells you where you are in the axis. Over here, it's one of the 6 patterns. So, the other concept that I want you to be aware of is spinal shock. Spinal shock is when you have upper motor neuron acute problem. Let's say I was in a car wreck and I came in the emergency room and I fractured my thoracic cord and was paralyzed. You're going to examine me in the emergency room and I'm going to have both legs weak, but I'm going to be flaccid. And I'm not going to have hyperreflexia initially. And why is that? It's because of spinal shock. So initially what happens when you get that shock, it knocks out inhibitory and excitatory input, so you tend to be more flaccid, and then within a week or two it's going to be hyperreflexic. If you've had a problem coming on for a long period of time, or for weeks or months, they'll present to you with a hyperreflexia initially. So it's an acute. That's why an acute stroke will initially be flaccid. You'll look at them 2 weeks later and they're starting to get hypertonia because it was an acute situation. And this is what we just talked about, distal worse than proximal, extensors and flexors, and that's the classic upper motor neuron pattern that you would see. Okay, before we go on, any questions about those concepts? Because I think those are really important concepts. Okay. Let's look at this now, because it's pattern recognition. So what I want you to do is start thinking patterns. It's very simple. There aren't that many patterns to learn. If you know the patterns, it's going to be real simple. So what can produce face, arm, and leg weakness on the same side of the body? What locations? Okay. Well, what did we talk about? It's not going to be cortex unless we got the entire cortex, which is how many processes are going to do that? Not many. So where is it going to be? We've got to get down below the corona radiata, don't we? Unless we had a huge corona radiata lesion, okay, which could happen, but it would be unlikely. It would be a tumor that you diagnosed a long time ago that continued to grow. So it's going to really be from the internal capsule down to what level? To the mid-pons, right. So it's real simple. You ever have anybody with face, arm, and leg, it has to be here. There's no other possibility. Okay, what can produce leg weakness? If somebody comes in and tells you nothing more than, I'm having weakness of my right leg, tell me what your possibilities of involvement would be. Say it's my right leg. What would it be? I'm sorry, what? Okay, so it could be lower motor neuron affecting either root or mononeuropathy, because we didn't tell you distribution. So it'd be lower motor neuron of the right leg. Correct, that's one. What else? Where upper motor neuron? Thoracic cord, which side? No, it would be same side. Because remember, it crosses. So if I get this side, spinal cord is going to be ipsilateral. Okay? So spinal cord would be right spinal cord, and it'd have to be below the cervical, wouldn't it? And what other possibility? Cortex, parasagittal. The anterior cerebral artery pattern. Now, how are you going to differentiate those? Well, very simple. You're going to start examining them, and they're going to have upper motor neuron signs or lower motor neuron, which are going to take you into one of those two distributions. And there's going to be other signs that would help you sort that out then very easily. But the first step is understanding the different patterns. So there's the three patterns. There's only three possible patterns. Okay? Now, what would be the findings with the T10 level total transection of the spine? What's going to happen to me? What am I going to look like? What are you going to find on my examination? Paraplegia. Okay. Now, if it's acute, I'm going to have reduced reflexes, but if it's been there a while, I'm going to have marked hyperreflexia, aren't I? And I'm going to have tone increase. I'm going to have Babinski's. Okay. My bladder is going to get knocked out. Okay. And what's going to happen to me we're talking about upper motor neuron, but what's the thing that helps you in the cord then is looking at sensory symptoms. And what should I have that's unique to the spinal cord that tells me immediately it's a spinal cord problem? What would be the sensory anatomical thing that you would see that tells you immediately it's cord? Okay. Around the umbilicus or everything below it? It's what we call a sensory level. If I have a sensory level, it has to be spinal cord. There is no other possibility that can do that. Spinal cord produces sensory level. So if I have sensory level and weakness in my legs, that is spinal cord. There's no other possibility. Sensory level, sensory level, sensory level, remember spinal cord. Okay? So, because I'm getting both sides, I'm going to knock out everything. And this is a total transaction. So I'm going to knock out pin and temperature. I'm going to knock out touch. I'm going to knock out joint position. I'm going to knock out everything. And that's going to be the classic transaction. What about a hemisection? It means if I took a saw and cut my cord right in half, okay, this gets back to what we were just talking about a minute ago when we were talking about one side of the cord. So motor, what's going to happen to me? Okay. Motor is going to go out on the ipsilateral side. Okay, what about sensory? What's going to go out on the ipsilateral side? Okay, posterior column, isn't it? Posterior column, so you're going to have joint position is going to go out. Now, you said touch. Touch will not go. And why does touch not go? Touch is bilateral. Touch goes through multiple tracks. It goes through spinothalamic, it goes through posterior columns, it goes through different locations. So you don't lose touch if you just have one side. You're going to have posterior column on one side, you're going to have motor on one side. And then what are we going to lose on the other side? Pain and temperature. Okay? So if you remember that pattern, that's really what you need to remember about differentiation of sensory and motor with cord problems. Okay? And here's the pictograph that shows you those phenomena that are there. Okay, what about bilateral leg weakness? What are the possibilities? You're in the emergency room tomorrow night. You've got a patient that comes in. They've had weakness coming over the last 24 hours in their both legs. You're there, and they're asking you, what do we need to do? Okay? So what are the possibilities? I'm sorry, I didn't hear you. I still didn't hear, I'm sorry. Muscle disease, okay? Why would that be unlikely? Could be, you could have acute muscle disease, but it would be unlikely. But what does muscle disease do? It's going to be much more widespread disease. So I'm probably going to be weak in my arms too. Muscle disease affects all muscles usually. It's more of a widespread phenomenon. So muscle disease would be very unlikely. Maybe have to put in my differentiation because they may be complaining of trouble getting up and they weren't aware that they're weak in their arms, but when you examine them, you're going to find weakness in their arms as well. So what else can give you bilateral? What are the possibilities of bilateral leg weakness? Spinal cord, we just talked about it. Both sides. Okay? What else? Bilateral parasagittal lesions in the cortex. What can do that? Meningiomas grow right in the middle. Compress both sides. Okay? What else could do it? Bilateral lower motor neuron. Cauda-Equina syndrome. Guillain-Barré. Starting and coming up the legs. Okay? Peripheral neuropathy that's getting legs primarily. Okay? So anything bilateral in that area would produce it. and we look at what are the possibilities. So again, there's only 3 possibilities. What I'm trying to show you is this is the way you really need to think about what you're doing. When you see a patient with motor weakness, what do? There's only so many possibilities. We've shown you there's 3 of this one. Face and arm, there's only 1. Okay? And if we go to other locations, like what if it's just face? Well, that could be localized in the cortex, in the frontal, just to the face, and it could be what? It could be a lower motor neuron facial nerve. Just 2 possibilities for that. But that's the type of thinking you want to do, and then what you can do is you look for other things that help you. What about locations, unilateral weakness of an arm and a leg? So that means 1 arm and 1 leg on the same side. What about peripheral stuff? Is that possible? Multiple lesions, yeah. We don't look for multiple lesions. What are the odds of that happening simultaneously? Are pretty low, aren't they? Unless you were in a car wreck, and then, you could knock out both. But it'd be very unlikely. So that pretty much throws that out. Neuromuscular, muscle disease, there's going to be more widespread. They're not going to just be one side. The one possibility that could do it, lower motor neuron, would be what? Think about the patterns we talked about. Anterior horn cell disease. Exactly. I could have anterior horn cell disease that's getting 1 arm and 1 leg lower motor neuron. Okay, so what else could do this? I'm sorry, what? So it could get one side of the spinal cord, couldn't it? And it'd have to be above, high enough to get arm and leg on one side. Where else could it get? Cortex, if you got arm and leg. And then what's the other possibility? Think about your tracks that I showed you. Well, it's going to be contralateral brainstem. From where? From the mid-pons down. Okay? So, it's ipsilateral, high cord, contralateral, brainstem, cortex, and then we just talked about the other one that unusual for lower motor neuron. You don't usually think of lower motor neuron with arm and leg, but the only one that really could do that would be anterior horn cell disease, where it involves those 2. Now, what could produce bilateral arm and leg weakness? Spinal cord, high spinal cord. Christopher Reeves, I don't know if you remember, that's what he had. Okay? Got both sides, spinal cord, neck injury. What else could do it? Think about your anatomy. What would be the locations that could do it? You could get bilateral, low, pons or medulla. Okay, first of all, I can tell you that'd be very unlikely, but it's possible. But what's much more likely? What about peripheral? Yeah. What about muscle disease? Okay, there's your muscle disease, arm and legs. What else could do it? Guillain-Barré gets what? It's a peripheral nerve disease, could get arm and leg, bilaterally. Okay. And then where else could we get it? You could go up into the cortex, again, very unusual, but you could potentially have trauma that knocked out both of these. Anybody that's going to do pediatrics, you're going to see that. What do you think cerebral palsy knocks out? Well, you see kids sometimes spastic on both sides from their cerebral palsy because anoxia knocked out these components of their motor function. And so we can see those are the locations. Peripheral, you get the upper cord, and as was mentioned, bilateral medullary pons, and then a high cortex. Okay, so we've gone through the main patterns that you're going to see motor-wise. And I think it's a lot simpler to understand that track that I showed you, to figure them out, than to sit there and try to memorize them all. And it's really quite simple if you learn that track and then think about where are the possibilities. And don't forget lower motor neuron processes being there as options. Okay, let's take a 70-year-old male, presents with gradually progressive tingling and numbness of the hands and feet. He also has noted some mild weakness distally in the legs. He has had no mental status changes, no bowel or bladder. Examination reveals absent DTRs, weakness and atrophy of the distal and lower extremity muscles, and reduced sensation to pen, touch, and temperature in distal, upper, and lower extremities. Okay, so is that upper or lower motor neuron? It's lower, okay? And what's the distribution? It's arms and legs, isn't it? So we just talked about that pattern. So what do you think this is going to be? There was only one pattern that would do that, and that would be what? Okay, why would it not be anterior horn cell disease? Because there's sensory symptoms. So that throws that one out. But good thought. If you didn't have sensory, then it could be. Now, let's say I was diabetic and had a peripheral neuropathy all my life and then developed, motor neuron disease. I might in the back of my mind consider that I've got two processes going on. But I don't like to do that. You like to put it under one process. So, it could be peripheral nerve. This would be something like you'd see with Guillain-Barré or any motor sensory neuropathy. And it's going to be, so it's chronic progressive diffuse degenerative sensory motor peripheral neuropathy. Because of the loss of sensation, they can get Charcot joints. They don't feel things. They get, blisters. So, signs of lower motor neuron neuropathy are going to be what? Well, we talked about early in this lecture. Weakness, hypotonia, reduced reflexes, sensory loss. And one thing I didn't mention is they can also get autonomic involvement because their nerves do carry autonomic function. And so you can lose that as well. This sort of gets to kind of what we were talking about when you brought this up about muscle disease. If we look at how do you differentiate neuropathies from myopathies, it gets up to what? Location and distribution. Proximal, this tends to be more peripheral for those. And then you get DTR changes in here. Both of them are going to not have changes in that. And then there's ways we differentiate them with testing that can be very helpful. Okay, 69-year-old male presents with a 2-month history of neck pain and right shoulder pain with associated tingling and numbness of the right index finger and thumb. 1 month prior to the evaluation, he noted increased difficulties with urinary frequency and impaired gait. Okay. Exam revealed weakness of the right deltoid, supraspinatus, infraspinatus, and biceps muscles with associated atrophy. Right biceps and brachioradialis reflexes were absent. He walked with a spastic gait, had bilateral Babinski's, his tone was increased in both legs, and all of his lower extremity reflexes were increased. Okay. And you're going, oh my God, okay. How do I deal with that? Okay. Well, what you always do when you have things together is let's simplify it. Okay. Don't get lost in the forest again. Look at look specifically, okay, at areas. So let's look and say, what up there is lower motor neuron? That's where you want to start. What's lower motor neuron? The dermatomal pattern, which is what pattern? Where would you put that dermatomal pattern? C5, okay. What else is lower motor neuron? Weakness and atrophy, okay. And if you took the weakness and atrophy, what's the distribution? Well, let's look at it. We got infraspinatus, what nerve? That's a root. Okay. what you're going to see is all of these supraspinatus, this is all different nerves, aren't they? But what are all of these? They're all one root. So it's C5, which goes along with our sensory laws. What else is lower motor neuron? Decreased reflexes. And where were they? Biceps and brachioradialis. C5, 6. So we got C5 involvement again. So we've taken all that, so what do we have? And it's all on one side, isn't it? So we have a right C5 radiculopathy. Okay? That's it, isn't it? So we now can kind of throw that away and think about, now, what's upper motor neuron? Spasticity in what? Both lower extremities. You got bilateral Babinski's, and you've got increased reflexes, and you got a spastic gait, and we have a neurogenic bladder. So that's both sides of the spinal cord. So, remember what I talked about in the beginning? We take signs, so we know that both sides of the spinal cord are being involved, but we have a C5. So where do I want to look? I want to look at the cervical spinal cord, don't I? This has been coming on gradually. So what could be there? I could have a tumor that's pushing against the spinal cord, that's pushing against the nerve. I could have a big herniated disc. I could have cervical spondylosis. But I know where my location is. I need one test. I want to look at the cervical cord. That's where the problem is. And how do you come to that? Because that's the only possibility. So we have a chronic progressive focal right mass, peripheral chronic progressive focal mass spinal cord, and this patient had spondylosis producing myelopathy and a right C6 radiculopathy. Very common. Very common. There's the deltoid atrophy and the supraspinatus and infraspinatus atrophy as well. The dermatome we talked about. Where's the C5 dermatome typically? You know, up in this area. Okay? Remember, it's the distal dermatomes that are important. So C5, you get into C6s here, C7s here, and C8s here. C8, you think about ulnar. C7, you think about median with that. Those are the two possibilities. And this one you think about mainly C6, and it depends on which side, but that could be radial as well if it's on the surface. And then we get up into this, which could be axillary. Is the other one that looks kind of like a C5. And they have degenerative changes in the spine. There's a myelogram showing the compression, and this patient needed surgical decompression of that. Okay, 52-year-old female presents with gradual onset of headaches, visual difficulties, right arm and leg clumsiness, and speech difficulties. Examination revealed papilledema, right lower facial weakness, right arm and leg weakness, increased DTRs, positive Babinski in the right, decreased sensation of double simultaneous stimulation of the right face and arm, and a right homonymous hemianopia. Okay, any lower motor neuron signs? Okay. Now, what are the upper motor neuron signs? Okay, increased DTRs. We got Babinski's. We've got right arm and leg weakness. Now, we talked about, you know, where can right arm and leg weakness come from, and we also had facial. Okay. So what's the face do? That takes us up, doesn't it? So we're thinking about it's got to be above the pons now, upper motor neuron. It's going to be the opposite side. And then what in there takes us to exactly where it is? Okay? Speech and right homonymous. Has to be up in the cerebral hemispheres, doesn't it? But what I want you to understand is if somebody has motor dysfunction, you can really place it pretty accurately. And then what do? You use the other stuff to really place it. And that's, you know, and you use your sensory, and you use your speech, and you use your vision findings. Now, sometimes you're going to have those alone without the other. But here's the papilledema in this patient. This is a slow-growing mass. It's a glioblastoma, and grows through the hemisphere. Now, here's somebody with a subdural that's chronic. Could it produce similar symptoms? It could. But one thing I want you to remember is that if I have an external thing like subdurals, it would never produce a homonymous hemianopia. Homonymous hemianopia needs to be inside, not compressing from the outside. So if I have somebody that presents with that, I knew it's a bad thing. It's inside their brain, not outside their brain. You'd hope it would be this, because this you could fix very easily. And you can get isodense subdurals. So they look like brain. You can get a scan. You're going to think, but this one's obvious because the brain's shifted over. But sometimes it's very difficult to see. So if you're still worrying, you find findings on your examination that suggest problems, you need to go on and do MRIs and other kinds of things to find that. Okay, 63-year-old male presents with a complaint of tripping on the toes of his left foot for the past 6 months while walking. 4 months ago, he noted progression of the left leg weakness and gradual onset of weakness in the right arm and left arm. 2 months ago, he developed dysarthria and dysphagia. He had no diplopia, bowel, or bladder dysfunction, or sensory complaints. Examination revealed hyperreflexia of the upper and lower extremities, atrophy with weakness and fasciculations of the tongue, decreased palate movement, nasal speech, and left leg and bilateral upper extremity weakness with atrophy and fasciculations. Okay. Sensory exam was normal, and Babinski signs were present bilaterally. Okay, so what's lower motor neuron? Fasciculations and atrophy and weakness. What is the pattern of weakness here? We look at the 6 patterns. Look down here. Sensory was normal. Okay? So that's going to make it very unlikely that we're dealing with what? Nerve, plexus. Plexus would be one extremity. It's unlikely to be nerve alone. And unlikely to be root. So that leaves us 3 patterns. Leaves us with neuromuscular junction, which would be what? Ocular bulbar fluctuating. Do we get that? No. Muscle. Would this be a muscle pattern? Possibly, but how did it move? It started one place and moved, didn't it? So what's the one pattern that does that? Asymmetric lower motor neuron is anterior horn cell. So you look at the lower motor neuron, there's only one possibility. This could be anterior horn cell. By looking at what happens to it, knowing the pattern. No other possibility. So, now we've got upper motor neuron stuff. And we've got upper motor neuron, which shows you have bilateral corticospinal involving the arms and the legs. And the reason I throw in this case is because this is a unique phenomenon. You have hyperreflexia in the face of atrophy. And all over, even in the distribution that's being involved below. And there's only one disease that can do that, and that would be ALS. Now, if he had pure lower motor neuron anterior horn cell disease, you could have everything here, but no hyperreflexia. And it would still be the same pattern. It's going to be a lower motor neuron progressive pattern. So this is ALS, and it gets the foot drop because of the weakness. You can see the asymmetric atrophy. Those legs would be fasciculating, okay, like the one I showed you. Atrophy in the arms, atrophy in tongue, they'd be fasciculating. If I put a needle in the muscle, I'm going to see these big units. I'm going to see fasciculations and see the other. And we get that ALS pattern. You're going to get what? Grouped atrophy is what you see with neurogenic disease. Is the pathology of that type of process. And that makes it. And then in this disease, the corticospinal tracts are damaged. That's why they get the upper motor neuron. So ALS is a unique disease that attacks corticospinal and anterior horn cell. There are diseases that affect pure anterior horn cell. Examples of that would be polio, your generation West Nile virus. Those can do that and produce that. And then there are diseases that we get others. In babies, it's Wernicke-Hoffman. In adolescents, there's Kuckelberg-Wiellander. These are all different diseases. They're all anterior horn disease. You don't even need to know all those names. You just need to know, you figure out it's anterior horn cell, you do that clinically. These are diagnoses that you are going to make clinically. There isn't a blood test that you can order to give it to you. Okay? And so it's a matter of examining them and figuring it out. But if you understand that it's lower motor neuron, upper motor neuron, and sorting it out, you can come to those type of determinations. Okay, 18-year-old woman presents with weakness of her lower extremities that has progressed for 3 to 4 weeks. 2 years ago, she had the onset of pain between her shoulder blades that began to radiate into the left arm and the left middle finger with associated numbness. The pain was accentuated by coughing, sneezing, or laughing. She had chiropractic manipulation, but the pain persisted. The left leg and more recently the right leg had become weak and numb. The past week, she developed difficulty with micturition. Now, one thing to remember is that pain is peripheral. You can get central pain, but it's pretty unusual. Most people that have strokes don't have pain. They may have a headache, but they don't get pain, in the extremities. A good example of that, I remember, this was a number of years ago, a patient came into the hospital, sudden loss of function in the right arm, screaming in pain. Intern admitted the patient, said they had a stroke, okay. We came on rounds the next morning, okay. I was chief resident at the time. I was going crazy. My attending really went crazy, okay. Looked at the intern and said, look, how many strokes have you seen that have pain, okay? And what had happened to this person, it wasn't a stroke, okay? He'd thrown an embolus to his arm, and it was all peripheral. Guy should have been in surgery 10 hours earlier, okay? Fortunately, saved the arm. It could have lost the arm, okay? And that's a matter of not understanding symptoms. And that's why you guys go through these courses and you think, oh gosh, I'm doing all this. Why am I doing that? I'll tell you why. Because if you remember the principles, I don't care where you are in medicine, you're going to be using these principles when you see patients. If you're working in the ER, you're working in an office, you're working in surgery, you're going to have patients that present with classical things that if you know the concepts, okay, you may not have to know everything, but you need to know the concepts of what can happen in different areas of doing that. Anyways, this patient is very similar to the other one. Again, had the findings of a C5, had the bilateral. And I threw that back in so you'd have that as a case, and I'm not going to go through that just for time. Let's just do the last case. 48-year-old female had gradual onset of difficulty with balance and coordination. She had tingling in her feet and leg and hands. She noted difficulties with falling while taking a shower or getting out of bed to go to the bathroom. She had gastric bypass surgery 1 year ago with 55-pound weight loss. Family felt she was having slow mental decline. Exam, decreased joint position in the upper extremities, hyperreflexia in the upper and lower extremities, decreased vibration, upper and lower extremities, mildly increased tone in the upper and lower extremities, mild difficulty hopping on both feet, positive Babinski's, positive Romberg, mild memory, and normal pen and touch. Okay, so how do you break that down? What's being involved here anatomically? Is there any lower motor neuron stuff? Okay. No. What's upper motor neuron? Okay. Increased tone, upper and lower extremities. Okay. And positive Babinski's. The hyperreflexia and increased tone. And it's bilateral. It's arms and legs, isn't it? Okay. What else is involved there? We look at other symptoms. I'm sorry, what? Cognitive, okay. And then what else? Balance. And why do you think they're having the balance problems? Okay. We'll talk about cerebellar on Wednesday, okay. But what else? Remember we talked about indirect pathways being affected. You could have a little bit of discoordination from the upper motor neuron with indirect pathways. But what else do we find here? We find that they have decreased vibration in the upper and lower extremities. And what else might you want to check in somebody like this? Joint position. So, somebody over here said it earlier, what's being involved? Not in this case, but an earlier case. Posterior columns. So what do we see? We're seeing bilateral corticospinal and bilateral posterior column. No involvement of pain and temperature. Okay? And so what could do that? Well, I could have a tumor pushing up at the back of my, meningiomas can grow at the back and push up against the posterior columns and be squeezing the cord, producing that. But we have lots of other clues, and one of them somebody mentioned up there is we have memory, don't we? So this makes you think, I'm dealing with something more widespread than just that. We've got more general symptoms. So if you start looking at the pattern, that doesn't fit. A local lesion in here wouldn't make my memory go, and it's not going to produce those kinds of things. So, anybody know what this is? Huh? Pernicious anemia, B12 deficiency, subacute combined degeneration. Okay? Something you should remember. And it's a B12 deficiency, and what's it do? It gets posterior columns and corticospinal tracts. It's reversible. I've seen acute cases of this. Now, what other things, if I have somebody present with spasticity in their lower extremities, always check B12, always check copper. Okay? Copper deficiency, okay, can do that. And then think about syphilis. Okay? Syphilis, B12 deficiency, and copper deficiency can do that. You don't want to miss those because those are reversible. And copper deficiency actually was, all the research in that is from a graduate of this institution, okay, who was a resident here. He's now the world's authority in copper deficiency, okay, and has described all the cases in the world, has made it very common. And, we'll see probably now in town 2 to 3 cases a year. And, and you don't want to miss it because these people will go downhill to wheelchairs, and it's you put them on copper and they cured. So you want to look for it. Same thing with the B12 deficiency. I had a young girl who was a therapist, physical therapist in Greenville. She went into her dentist. They gave her nitrous oxide to do a procedure. While she was there, she suddenly couldn't move. They shipped her down to us, okay, and looked at her clinically, and she had clear corticospinal and loss of joint position. She had acute B12 deficiency. Nitrous oxide precipitates that in people that are very low. It took her a year of B12 to get back to normal. And, she was bedbound for about 2 months. So it's one of those things, if you're slowly becoming B12 deficient and don't know it, that nitrous oxide can tip you over the edge, and it can happen. And it'll precipitate it. So spinal cords that are bilateral, particularly if they have posterior column, because all those do posterior column, those are the 3 things you want to check. Okay? In the spinal cord syndromes. Okay, I'm going to stop there. I'm not going to do the last one. The last one's in there for interest, and we'll talk a little bit more about that later in the year. Any questions? Okay. Thanks.
If anybody didn't sign, the sign-in sheet is still here. It's still down here. There are a few missing signatures. Let me see, is the time? One more time. All right, let's go ahead and get started. I think this will be fairly short. It's got this very fancy title called Motor Integration, which is a very big title for a very small lecture, actually. Is it a little bit down? Okay. Alrighty, let's see. The question always is, which one is it? Is that it? Did it go up? No? How about that one? No? How about that one? Okay, I've got them. Yeah, okay. Alrighty. Okay, so all I'm going to try to do here today is fill in a little bit of a gap between what Dr. Beaumont talked to you about in terms of all of those tracts coming down into the spinal cord doing things in the motor system, and what Dr. Kimbrough just talked to you about in terms of the corticospinal tract and the changes that occur in the motor system when the corticospinal tract is disrupted. So what I'm going to be talking about is I'm going to be talking about tone, I'm going to be talking about the gamma motor system, and then I'm going to be talking a little bit about what those descending tracts that he said not to think about for his lecture, what they're doing, and why they become important when we have something that knocks out one of the other tracts, okay? So, start off very simple here, very simple review of what goes on at a muscle. You have extrafusal muscle fibers and intrafusal muscle fibers. The intrafusal muscle fibers, of course, are part of the muscle spindle organ. And the extrafusal muscle fiber is innervated by an alpha motor neuron. The intrafusal muscle fiber is innervated by a gamma motor neuron. When you have, I think you're all pretty familiar with the basic function, right, of the muscle spindle. It is in parallel with the fibers of the muscle, and it reports on the state of stretch of that muscle. So in order to report on the state of stretch of the muscle, it also has to have a certain amount of tension on it at all times, so it can report when there's a change. Now, the gamma motor neurons play a significant role in muscle tone. If you have activity in a gamma motor neuron, you're going to cause some contraction of that intrafusal muscle fiber, okay? And that's going to stretch it, stretch that primary sensory ending. The primary sensory ending is going to send its information back to the spinal cord. It's going to act on an alpha motor neuron, and it's going to increase the excitation state of that alpha motor neuron, okay? Now, sometimes that can be strong enough to lead to contraction. At other times, it's just making that motor neuron a little more excitable, right? So it doesn't actually contract the whole muscle or even necessarily that motor unit, but makes the alpha motor neuron a little more ready to fire with any more little input from somewhere, right? So that's the tone. It's setting the tone of the muscle system. So my definition of tone is the physiological one, which says readiness to fire, okay? When there's increased muscle tone, the muscle is more resistant to movement, okay? Now, in normal movement, when you have all descending tracts that are intact, I'm going to be focusing on the descending tracts, right? Assuming you get the idea in the spinal circuitry, what the monosynaptic reflex is. If you have excitation of you want to make a movement, okay? One thing I was going to say first, I think. Let's see. Okay, yes. So in the spinal cord, these are from Dr. Beaumont's lecture. And he told you about, in the ventral horn of the spinal cord, of course, you have a somatotopic kind of organization with the axial muscles. Motor neurons going to the axial muscles are located medially, and motor neurons to the distal muscles are located more laterally. You have gamma and alpha motor neurons distributed within there. So they're all distributed somatotopically, and they're all mixed together, right? So if you have a normal movement, you're going to excite, let's say, one of the muscles to contract. If the muscle contracts and the muscle spindle is released, there'll be this little pause in this firing of the afferent from the muscle spindle because it's been released from tension, right? That all makes sense to you. You've seen that before. And you don't want that to happen, right? You want that spindle to continue to report on the status of stretch of the muscle. So the gamma motor neuron acts to increase the tension back on the spindle. Okay? So, on the other hand, in the muscle that opposes it, it has to be prepared to stretch. One thing you don't want to happen is you don't want to stretch that muscle and have your gamma motor neuron fire, because that's going to be counterproductive, right? So you need to send inhibition to the gamma motor neurons for the spindles in that muscle that you want to stretch, so that that gamma motor neuron, that spindle, will not be tense. It will be relaxed in coordination with the stretching of the muscle, right? Okay. And at the same time, you have to grade that inhibition, because you still want to keep your spindle firing when something unexpected, when some kind of inappropriate stretch occurs. It still has to be sensitive to that. So that's all this says, basically. As you're increasing your contraction because how much weight you're carrying is changing, you have to keep all these muscles either stretched or contracted, and the muscle spindles have to be in the appropriate state to remain dynamically functional. So you also have to have ongoing input to your gamma motor neurons, right? So it's coordinating gamma motor neuron and alpha motor neuron output. And as I said, if something unusual happens, like that full can of soda falls into the glass and you're not expecting it, you still have to have those spindles working appropriately. Yeah? It is supposed to be gamma. Sorry about that. That's delta. Sorry. Guess I didn't pick out the right thing. So the supraspinal influences have a lot to do with coordinating the gamma and alpha motor neuron discharge for any intentional movement, You can have, as I've said, both inhibitory and excitatory influences on the gamma motor neurons. You're going to constantly keep that spindle circuitry at some kind of level of tone so that it can report changes in stretch. And you're going to also want to anticipate the effects of a planned muscle contraction or stretch or whatever, so that you both control in your intentional movement gamma and motor output, all right? So you have to have a sort of predictive impulse to your gamma motor neuron to keep it appropriately functional. Now, all of the, when I say the descending motor control systems, do you all know what I'm talking about, right? I'm talking about a variety of them. I'm talking about what we just talked about for the last hour, the cortical spinal systems, or cortical pontine, cortical bulbar, rather, excuse me, cortical spinal, cortical bulbar systems, the descending rubrospinal tract, the lateral reticulospinal, medial reticulospinal, lateral vestibulospinal, medial vestibulospinal. Okay, all of those tracts come down to the spinal cord, and when they act, they're of course acting to change the balance of inhibition and excitation that's present in the reflex circuitry that's already there. Okay, and they can act on that reflex circuitry in a couple of ways. One of the things they can do is they can give direct inputs to the alpha motor neurons. It's not really, really common. If it happens, the cortical spinal tract does that to some muscles. It can have excitation to various different interneuron pools. By interneuron pools, I just mean groups of interneurons that are in there and have maybe slightly different functions. Some of them are segmental and they're restricted to the segment. Some of them have projections that extend a few segments in the what we call propriospinal types of interneurons. But those are interposed in there, and a lot of the descending input comes down to interneurons. As Dr. Beaumont said, that's the most common thing to happen, is for these descending tracts to end on the interneurons. Some of them have direct input to gamma motor neurons, and then they have a fairly powerful control over the tone that's being set from the gamma motor system. And some of them can even synapse on afferent terminals and change the way the sensory information is coming in to the spinal cord. And I'm putting that in there for completeness, but just that those are the possibilities for the ways in which these descending tracts can influence the motor system. So what happens, let's just look at what happens if we do remove the cortical spinal system from its inputs into the spinal cord. I'm just going to kind of limit it here, mostly to the spinal cord, although this is also true for the inputs it has into the brainstem, cranial nerve, motor nuclei as well. So the corticospinal tract, most of its descending influence is over flexors of the distal limb, okay? So if you look, when you trace the pattern of distribution of the terminals of those axons that come down from the motor cortex, they terminate mostly on motor neurons that are involved with muscles of the distal flexors, okay? So if you take out that corticospinal tract, what do you have left that can function? I'm really kind of asking you that question. What other parts of the motor system can still be functional? Well, the interneurons will certainly be functional, but I'm thinking more about the descending regulatory systems. Now, the cerebellum, that's interesting, because yes and no. Now, the cerebellum, of course, most of its output, or a lot of its output, goes to the thalamus and then to the cortex. But now you've wiped out the cortical spinal tract, so that part of the cerebellum just doesn't have a channel to act through, right? So it can't really do anything when we take out the cortical spinal tract. Same is true for the basal ganglia, right? Most of their output into the thalamus goes into the motor cortex. If the output from the motor cortex isn't working, then the basal ganglia can't exert its influence either. Now, I said yes and no about the cerebellum, because what else does the cerebellum do? It goes into the reticular formation. It can influence reticulospinals. What else? It can go into the brainstem and affect the vestibulospinals. Okay. Are they still functional? They're still functional. Okay. What else? What's the other thing that the cerebellum sends input to? The cerebrospinal. Right. So that's still functional too. Okay. So you've taken out the corticospinal tract. You've eliminated the effectiveness of the cerebellum and the basal ganglia, and all you really have left are these brainstem tracts to work, right? And their input into the spinal cord becomes much more important in what you can actually see in the behavior, in the motor behavior, right? Makes sense? Okay, so what do you see when you lose the corticospinal tract? You get weakness and paralysis of the muscles in a particular area of the body, in a part of the body, okay? And I think it's pretty straightforward to understand that if you remove what is essentially an excitatory tone, the facilitation of movement that comes from the corticospinal tract, that you've eliminated that to the alpha and gamma motor neurons both, right? And that is going to make it more difficult to carry out movement because you're just not having the right amount of excitation getting to those motor neurons, okay? Did you also get hypertonia, hyperreflexia, and spasticity? Before I leave this muscle weakness thing, a very big point was made that you have differential effects, right? You get hyperactivity in the flexors of the upper body, hyperactivity in the extensors of the lower body. And I just told you that most of what the corticospinal tract does is to the flexors. So you would imagine if you removed input to the flexors, excitatory input to the flexors, that your extensors would become more dominant, right? So the lower part of the body makes sense. Take out excitation to flexors, you get more excitation, hyperexcitation, relatively speaking, of the extensors. But why do you get this funny thing that goes on in the upper body? Why is the flexor tone still so good? I'll come back to that in a minute. And then there's this question of hypertonia, hyperreflexia, and spasticity. How are these explained? Why do you get hyper anything when you're removing an excitatory input from the corticospinal tract? Okay. So the gamma motor system is one possibility. And I'm going to talk about that a little more in detail as we go on. You can imagine that if you change the inhibition or excitation pattern to the gamma motor neurons, that you would affect tone, because we just said it's very important in affecting tone. And that changing that tone would also increase the excitability of the stretch reflex. And that could produce some hyper-reflexive behavior in the muscle. Yes? Makes sense. Okay. So how does that happen in terms of these tracks that can influence the spinal cord? As far as the differential effects, I'm going to show you some diagrams of this in a moment, but for right now, I'll just kind of tell you what we're going to be talking about here. The upper extensors and lower flexor issue, we have to think about the cerebrospinal tract, because that's one of our tracts that's still functioning, right? Now, the cerebrospinal tract in humans only goes to the cervical levels. Oh, well, maybe that makes some kind of sense, right? Because we've got lower limbs acting differently from upper limbs. We've got a tract that only goes to the upper limbs. Maybe it's playing a role here. Yeah, maybe. But the problem is, it behaves like the corticospinal tract. It's mostly to flexors. Oh, well, but that makes sense, doesn't it? Because we have a little hyperflexive tone in the upper limb after we remove the corticospinal tract. It's still not quite clear to me, I don't know if it would be to you, why you get a hyperflexive tone when you've already taken out some excitatory input to flexors. Okay? Still a little confusing, but we do think the cerebrospinal tract has something to do with it. We don't really quite understand it, because if we then take out the cerebrospinal tract, after we've taken out the corticospinal tract, what happens? You go into extensor tone in the upper body. Okay? I'll show you that in a little bit. Okay, so we have a possibility here that the cerebrospinal tract is important in regard to what kind of effect you see in the upper body when you have a corticospinal tract lesion. What about the hyperexcitability of the gamma motor neurons? Well, there's not a clear answer to this question, but I can tell you what people sort of think. One possibility is that for some reason the corticospinal tract just has more inhibitory input than excitatory input to the gamma motor neurons, so that when you remove the corticospinal tract, you're removing more inhibition than you are excitation. You end up with a slightly overexcited population of gamma motor neurons and alpha motor neurons too. So the tone is increased from that. People haven't found a lot of evidence for that. It still remains a possibility. But the one thing that they have focused on is the role, in this case, of the lateral reticulospinal tract, okay, which comes from the medulla. Because the lateral reticulospinal tract has very powerful gamma motor neuron inhibition of gamma motor neurons to the extensor system. Okay? But it's under cortical control. If you remove the cortical control of this that goes to the medulla, the reticular formation of the medulla, you can't excite this pathway very easily. So when you wipe out the corticospinal tract, you also essentially remove the lateral reticulospinal pathway from working correctly. And since that gives you a lot of inhibition, you've pulled out a whole lot of inhibition, and you get a hyperexcitable state. Okay? So when the corticospinal tract is damaged, you're changing the influence of several of these systems as they get expressed on the spinal cord. The medial reticulospinal pathway, on the other hand, is the facilitatory one. It doesn't require a lot of cortical input, so it remains intact and it's excitatory. And then you also have vestibulospinals that are excitatory. So here's the kind of diagram of where we're working. Okay, we're assuming now that the corticospinal tract has been wiped out, right? And I'm not showing you here that we've removed its influence on our alpha motor neurons and gamma motor neurons, but say we have done that, okay? Mostly on the flexors. Here are our brainstem motor centers in the medulla and the pons. The lateral vestibular nucleus, the medial reticular nucleus, if you will. These are all parts of the reticular formation. And this is the lateral reticular formation in the medulla, the lateral reticular tract, which originates in the medulla, and the medial reticular tract, which originates in the pons. Why is the medial vestibular tract not up there? What does the medial vestibular tract control? It's really only responsible for movements of the head and neck, upper body, okay, upper back. All right, so it's not going to be involved very much because of its restricted effects, okay? Mostly it goes to a very limited number of muscles. All right, so we have those three systems in the brainstem. They're still working. We have this input that I said comes to these areas from the cortex also. They're under control. okay? We're calling them cortico-reticular fibers, okay? Input from the motor cortex. It's part of the descending system that goes into the brainstem, okay? And it comes in and it regulates particularly this system. Doesn't do all that much here, but it has a very important excitatory input on this, which is our lateral reticulospinal system. This is supposed to be, this is our spinal cord down here, okay? These are alpha and motor neurons in the spinal cord. We're showing this pathway, lateral reticulospinal, with its very inhibitory effects. And we have medial reticulospinal and the lateral vestibulospinal, which are excitatory. All right, so if we eliminate the cortical spinal tract, or those descending, and also, now all this is above the medulla, so we're also getting the stuff that's coming down into the brainstem. So we're also wiping out these, okay? Doesn't do much here, but it removes a lot of excitatory input to that pathway. So it doesn't have much output, all right? When it doesn't have much output, it can't exert much inhibition down here in the spinal cord. So we have overall increase in extensor tone because these facilitatory, these excitatory inputs are mostly onto extensors. Okay, so we have an increased extensor tone that comes out as a result of this sort of side issue of disturbing the corticospinal tract and the descending fibers in it, okay, via a change in the lateral reticulospinal tract. So then we have two other tracts that are still functional, from the lateral vestibular nucleus, the lateral vestibulospinal, and the medial reticulospinal, and they are now acting unopposed, right? So you have increased excitation, you've got increased tone in the motor systems that results from this. Okay, but then what's that thing about the upper motor nerve, about the upper limbs? If we've got that increased extensor tone everywhere, why do we have this? And again, it has something we believe to do with that rubospinal tract. Because as I said, if we interrupt it, we lose that flexor tone in the upper body and we get extensor tone just like we do in the lower body. It's not entirely clear how it does that. In humans, it's a very small tract. It doesn't seem to be that potent. But remember, it has a very strong impact on the cerebellum. So it may be acting indirectly through the cerebellum to make changes in those other systems that are still functional. Somehow, okay, it seems to have some responsibility for maintaining this position in the upper limb. And of course, one of the reasons I'm talking to you about all this loss and this increase in the excitation is to try to explain the spasticity, right? We have a hyperexcitable monosynaptic reflex. That's characteristic of the term spasticity, all right? So that, you have a muscle that if you move it fast, you get a hyper response back from it, okay? This can become clonus if you continue to try to stretch the muscle, right? You can get that, as Dr. Beaumont showed you, you can get with his foot, though not with his arm. You get that repeated cycle of stretch, reflex, stretch, reflex, stretch, reflex. And it's certainly probably one of the reasons why you see it so much in corticospinal lesions, because of the removal of this inhibition on the system. You don't get quite as much problem with spasticity if we're going down now below the level of the medulla, or actually the mid-pons, as Dr. Kimbrough said, because now everything that goes off into the brainstem to affect these other descending pathways has already done so when you get into the spinal cord, right? So if you get a pure lesion of the corticospinal tract here, you don't get as much spasticity because you are not affecting those brainstem circuits, okay? Because you're below the level at which you can influence that input into those brainstem circuits. But you have to remember what's lying very close in the spinal cord: the lateral reticulospinal tract and the rubospinal tract. So you can also damage those in a lesion of this area of the cord. So it's not true that you will never see spasticity. It depends on how much damage you get in here, okay? Because they're all coming down pretty much together. Okay. Clinically speaking, one of the important things that happens is if you have a really extreme case of removal of cortical motor control over these descending systems, you get a decortication state. You have a decorticate preparation or a decorticate patient. In other words, the entire cortex, at least as involving the motor system, has been destroyed. It's not just primary, it's just secondary, but also some of the premotor areas of the cortex are destroyed. And you get this phenomenon that's called decorticate rigidity. It's really not named very well, because remember, rigidity, as Dr. Kimbrough explained it, and I think Dr. Whaley also did too, rigidity is the term that's used to describe the behavior of a problem with the basal ganglia, because you have equal difficulty moving it in every direction around the joint. Okay, this is related to spasticity, the phenomenon we were just talking about, okay, with the hyperexcitable monosynaptic reflexes. So it's really decorticate hyperspasticity, if you will. But the term that's used is decorticate rigidity. So if you have that kind of damage to the cortex, you end up with an extreme variation of the posturing that Dr. Kimbrough just described to you that is typical of corticospinal tract, okay? He says if you see someone with a stroke, they're lying in bed like this, right? A decorticate person has hyperextended lower body and hyperflexed upper body, okay? Decorticate. One of the ways this happens is if there's an increased pressure building up, intracranial pressure is building up. If you have a very big bleed or something like that, and you start to get pressure that deforms the cortex and inhibits the function, right? So that's bad, okay. That kind of pressure can progress. It can progress fairly quickly if the bleed is bad, and it can start having expression down into more parts of the brain. You get more compression, you get more movement of the brain, you get pressure on the midbrain, and then what happens? Well, suddenly it doesn't work anymore. Your red nucleus is affected. Your rubrospinal tract doesn't work. And you lose the decorticate posture, and you go into what's called decerebrate posture. That's where you've lost the flexion tone, and now everything is hyperextended completely. I'm going to show you a little video that shows you this change in the motor pattern. This is not a good sign, okay? It means that you've got progressive damage into the brainstem. And if it progresses further, the only thing that's working now are those reticular system descending motor. If they go, you haven't got much brainstem function left, right? So that's usually fatal. It's very hard to recover even from this stage if it happens. and there's a little point here, which since Dr. Kimbrough mentioned spinal shock, when you get compression of the midbrain and compression of the brainstem to produce these rigidities, you don't go through a flaccid phase like you do when you have spinal shock, okay? As soon as you start getting compression, you go into the rigidity phase. Nothing ever becomes relaxed. Oops. Okay, now this is supposed to be a video. See if I can.
Patient is in the decortica position with the upper extremities in flexion, the lower extremities in extension, reflecting that the brainstem motor centers are working, but we don't have modulation of those centers from the corticospinal tracts and their connections to the brainstem centers. If we now go a step lower as far as the level of dysfunction and eliminate the function of the rubrospinals, we go from decorticate to decerebrate posturing.
Notice her back arching and her neck.
The lower extremities stay in extension. Now the upper extremities are in extension because we don't have any type of regulation or modulation of the vestibulospinal or the reticulospinal tracts, but we've eliminated the influence of the rubrospinal tracts at this point in time. If there's to be further progression and the patient has further deterioration, and we now eliminate the function of the vestibulospinal and the reticulospinal tracts, the patient would then become flaccid. And dead.
Did you notice that when the patient went into supposedly complete extension, that there was also, went through the back and the neck and the head, all the way into complete extension? I'm probably, let's see what comes up next. Okay, yes, this is a question for you now, and it's to remind me to make this point, which I may have not made as clearly as I should when we first went through. A 37-year-old man suffers a massive brainstem stroke, destroying much, if not all, of the midbrain and leaving the patient unconscious and unresponsive to any sensory stimulation. He presents marked rigidity in his limbs. Which of the following pathways best accounts for the rigidity due to its now unopposed actions? Everybody want to think about that one for a minute? Okay. Is it the rubrospinal tract? No, because we don't go into that full rigidity. Is it the corticospinal tract? Is it the mediovestibulospinal tract? How about the lateral reticulospinal tract? Is that still acting unopposed? That's the one that's sort of been taken out. Remember, we removed that inhibition from that one. The lateral vestibulospinal is still intact. The medial reticulospinal is still intact. And of the two, this is the point I want to make, of the two, the lateral vestibulospinal tract is the one that has the greatest power. It's extremely powerful excitation of gamma and alpha motor neurons to the axial and postural muscles, because that's what you've got left. You've got axial and postural muscle systems, right? And when it's particularly powerful in the extensors. So when it's remaining to function, that's basically all that you're going to see. Okay, and this just explains what we went over. Now, this phenomenon of decerebrate rigidity doesn't have to occur in this sequential way I just described it, of damage to the cortex followed by damage to the midbrain. Okay. You can produce it by simply cutting the brain, cutting off all of this, but that's no big deal, right? That's how they experimentally first described this. You just cut below the level of the rubrospinal, of the red nucleus, and you'll get this spinal systems working to produce hyperextension. But another way that you can do this is with big strokes in the dorsal pons. And that's a little mysterious if you think about it, because you haven't really removed the corticospinal tract, right? So you go into this hyperposturing without going through the loss of the corticospinal input. But when you do that, you have still removed, by having this lesion in the pons, you have removed the input that normally controls the lateral reticulospinal. And you have removed its inhibitory effect. And of course, if you've made the lesion in the pons, you've removed the rubrospinal tract too. So you've removed both of those components. And you still go into the posturing, okay? So it doesn't require that you remove the corticospinal tract first. Apparently, this phenomenon can overpower the corticospinal input. Presumably, you're also not conscious at this point because you've destroyed a lot of your reticular formation, right? An 80-year-old woman displays marked rigidity following a stroke. Which of the following brain regions is the most likely location of the stroke? And again, when you see that word rigidity, if I saw this word, this question, and I saw the word rigidity, the first thing I'm thinking is basal ganglia, okay? But then I look at my choices and I see, well, they're not talking about that kind of rigidity because there's nothing on here that relates to basal ganglia function as an option. They must be talking about some other kind of rigidity, right? Decorticate or decerebrate. Well, there's nothing on there that really suggests corticospinal tract either, so I'm going to eliminate decorticate as a possibility. Does that make sense? Do you see what I mean? There's no area of suggested stroke where you would get a corticospinal tract lesion. Okay, so can we eliminate? Can we eliminate posterior half of thalamus? Yeah, pretty much, right? That's going to cause us, we might get some, we might affect the lateral geniculate, medial geniculate, we will affect the pulvinar, so we might get some problems with visual, motor sorts of coordinative things. We might get problems with some pain. We could be affecting the VPL, VPM. We get, okay, sensory loss, okay. No. Anterior hypothalamus. Right, we don't have anything really to do with the motor systems. Autonomic systems, yes. Temperature regulation, yes. Maternal sexual behavior, yes. Okay. Dorsal half of midbrain. Okay, superior colliculus, inferior colliculus. I mean, what's in the midbrain that could have an effect here would be the red nucleus, but this is the dorsal half. Red nucleus is deeper, so that's not going to do it. Ventral horn of the spinal cord? No, that's not going to, because that's lower motor neuron disease, right? Flaccid. Dorsal half of the pons is really the only option that's there, and based on what I just told you about how that is an area you can generate this kind of problem from with a serious lesion that wipes out a lot of the reticular formation, that would be the choice there. Just the dorsal half? So not including the belly of the pons, not including the corticospinal tract or the, okay. Okay, no, just the dorsal half. Yes.
That could occur at the level of the midbrain.
Yes, but it's still, the intercollicular is going to be, you're going to be cutting. You're going to have loss all the way down but you're going to be below the red nucleus, right? But that is not just the dorsal half. That's not just the colliculi and the upper part of the midbrain. That includes cutting down through the base of the midbrain, which would be where your rubrospinal tract would be. Does that make sense now? Okay. Dorsal half of the pons. And that explains it again if you want to go through that. Okay, so one more. A 61-year-old woman went to the emergency room after 2 hours of left face and arm weakness. On examination at 8 a.m., she was fully alert and with mild left face and arm weakness, completely sparing the left leg. She had a history of atrial fibrillation, which can cause blood clots to form in the cardiac atria as a result of stasis of the blood, that is, right? For this reason, she was taking the oral anticoagulant warfarin. However, blood tests in the ER showed that she was not adequately anticoagulated on her current dosage. It was felt that she most likely had an embolus from the heart to the right side of the brain. A head CT within 3 hours of onset was unremarkable. This finding was consistent with the diagnosis, as it can take from 6 to 24 hours for an acute stroke to become visible on CT. She was therefore admitted to the hospital and started on an intravenous anticoagulant, heparin, in order to rapidly achieve a therapeutic range of anticoagulation. Okay, we're trying to prevent future emboli, right? The patient remained stable through the day, but at 10 p.m. she was suddenly found to be unarousable. Exam was notable for fixed, mid-sized pupils, no extraocular movements, and bilateral extensor posturing of both arms and legs. Respirations were shallow, and she was intubated. Okay, so where is this bad damage? What are we seeing? Where is this damage that we're seeing the effects of here? Got any cranial nerve signs to tell us? Well, that's the cause, probably, but what does that sign, what are the signs there that tell you where? In the brainstem, okay? Cranial nerve signs are the lack of movement, no extraocular movements, and fixed pupils, right? 3, 4, and 6, probably, all. Big brainstem problem, okay? And she's got extensor posturing of both arms and legs. And that would be consistent, right, with possibly, since this evolved, possibly with increased intracranial pressure as opposed to a limited lesion, right? But we don't know exactly right now. Except, of course, we have been giving her an anticoagulant. And as a matter of fact, what happened was that the area where the original stroke was, there was now a huge bleed as a result. Okay? And you can see how it has distended the brain and causing compression of some of its components parts. And in fact, if you look at the brain stem in this patient, here's a normal, here's the, as they say, baseline scan. Here's the cerebellum, midbrain. Here's the uncus of the temporal lobe over here and the horn. After her bleed, okay, oh my goodness, what's going on here? No spaces left, basically. Cerebellum has expanded into this whole area. The brainstem has been forced down to areas where there's not supposed to be any brain. This, the temporal horn of the ventricle is much larger because there's been blockage of the flow of the CSF out of it. And the uncus has been pushed towards the midline as well. Okay? So there's been multiple herniations in the brain as a result of that bleed. So that can be a way in which, that's a kind of a sequence in which you can develop this hyperextension. She still had some brainstem function left, just enough for those lateral vestibulospinal and medial reticulospinal to still be working, but not much else. And at this point, the true case history is that the patient did not recover from this, and the family decided not to try anything heroic to try to help her to do so. So this undoubtedly progressed until the brainstem was no longer functional. Okay, I'm sorry I've kept you over. There's one more case on here that you can look over because it's got a good explanation, and it's not quite the same thing. It's a little bit different than on these systems. Okay, so hopefully that kind of spanned corticospinal into some of these other systems and what they do and why they might be important clinically. Anybody got a question? I'm here. Come see me after class or whatever.